So my disclaimers, and then, so let me start off with a brief introduction to evidence-based medicine. I'm sure we're all familiar with it because this is what we do day in and day out subconsciously, but let us just refresh on how it came about and what the definition of evidence-based medicine is. So when it was first defined in the early mid-1990s, evidence-based medicine was defined as the integration of clinical expertise with the best available external clinical evidence from research, taking into account individual patients' preferences and values. So there are three main pillars for evidence-based medicine. Our clinical expertise, that's why we train for so long and we spend all these years in gaining the expertise, but also integrating that with the best available evidence. And at the center of all of this, the most important aspect is our patients. All what we do is for our patients, and the patients should be our main focus. So research, again, should be focused on patients and nothing else, not to enhance our research output, but to improve clinical care and clinical outcomes for our patients. So just let us again refresh on the various types of clinical research. Again, we've had all this, learning during our undergrad, postgrad days, but let us just refresh. And this diagram is very simple in the way it summarizes the different types of research. So let's start off with the top box in asking a question. Did the investigator assign the exposures? Did the investigator assign the exposures, treatment, or intervention? Now let's move to the left side or the right side, whichever. So left for me and the right for you, and let's go down that side and look at the various types of studies. So if the investigator did not assign the exposure, the intervention or treatment, say I was the investigator and you were the investigator, then if we did not assign this, then it becomes an observational study. And then in the observational study, if there's a comparison group, it becomes an analytical study. If there is no comparison group, it becomes a pure descriptive study. And within an analytical studies, the types of studies depend upon the direction or the timing of the exposure and the outcome. So if you look at the boxes right at the bottom, the types of observational studies, analytical studies, whether there are two groups, the exposure, the intervention treatment group, and the control group, what are the different types? We can then define them based on the timing of the exposure and the outcome, or the direction of the exposure and the outcome. So if we look at the exposure first and then look into the outcome, then it is a cohort study. If it is the outcome first and then we look at whether we have the cases and the controls, which is the outcomes, and then we look whether they had the exposure, the intervention or the treatment, or did not have them, then it is known as a case control study. Case control study is useful when the events are very rare. That is where case control studies are most useful. And then you have the exposure and the outcome at the same time, then it becomes a cross-sectional study. So we have come across several cross-sectional studies during the recent COVID times where at one point we were looking at exposures and outcomes in terms of mortality, morbidity, and so on. So these are the various types of observational studies. Then on the other side, we look at the studies where we assign the exposure. That is, the investigator, you, I, or somebody else assigns the exposure, and then it becomes an experimental study. So it's a study in experimental setting. It's not in real-world setting. And then again, depending upon whether we assign, this investigator assigns the exposure, intervention, or treatment randomly, it is randomly allocated or not randomly allocated, then it is a randomized controlled trial or a non-randomized controlled trial. Yeah. So this is a very nice figure that summarizes the various types of clinical research studies. So we've looked at the observational studies, we looked at the various types of observational studies, and then we said, we can get we can analyze real-world data, real-world evidence, provide real-world evidence from observational studies. So what is real-world evidence? Real-world data is data derived from several sources associated with outcomes in a heterogeneous. So you would selecting the population. Yes, we are defining the population, but we are not selecting the population. So it is more heterogeneous population in real world settings. That is, it's not an experimental setting. So as we saw in the previous figure, experimental settings becomes a randomized controlled trial or a non-randomized controlled trial where we assign the exposure, the intervention or the treatment. Here we are doing it in routine settings, not in experimental settings. And real world data can be derived from health records, from registries, from other sources, which we will come on to in the next slides. An analysis of this data provides real world evidence, and we will go into some examples of how we have adapted our clinical practices and how clinical practices have evolved from real world evidence. Randomized controlled trials. I don't have to go through this busy slide. This is very familiar to us. We all know what randomized controlled trials are gold standard in providing evidence. They are at the top of the evidence pyramid for primary research. But again, randomized controlled trials are not easy to conduct. They provide the best evidence, but they are difficult to conduct. There are strengths with the randomized controlled trials in the sense that it limits the bias. So, again, the randomized controlled trials have to be evaluated in how good they are or how robust they are. Not necessarily every randomized controlled trial is very robust. We have to evaluate further, but they provide the best evidence if they are well conducted. But again, there are weaknesses with randomized controlled trials in the sense that you usually set a randomized controlled trial to assess any differences for a defined primary outcome. So you can't look at several outcomes. It's much more, it's complex. You will probably look at a defined primary outcome and then secondary outcomes, which sometimes we can't make any conclusions for secondary outcomes. Again, with randomized controlled trial, we have a set protocol and we define our populations. It is less homogeneous. It is more homogeneous or less heterogeneous compared to real world evidence or real world data, which is from daily clinical settings. And with randomized controlled trials, as you are defining a specific clinical question and then you're designing the trial, you have limited sample sizes to address only that clinical question, and you cannot make conclusions, or you should not make conclusions beyond what you set out to do with randomized controlled trials. Whereas with real world data, you have the data available and you can set up various research questions to address So what are the advantages and disadvantages of real world evidence or real world data? There are advantages, but also there are limitations and disadvantages which we should recognize and also be aware when we formulate conclusions from the results. So the real world evidence can provide information on treatments in patients groups usually excluded from RCTs. So we've said in the last few slides that with regards to randomized controlled trials, it's a specific defined homogeneous population, and we should not be extrapolating the evidence from that study to beyond or to our populations other than what it is defined in that study. Whereas with real world evidence, it is daily clinical settings, so we have a heterogeneous population in which we can formulate questions and address from different populations. We have the advantage of large sample sizes, especially with registries. It's quicker, less expensive. Randomized controlled trials are very expensive, and we can assess broad range of outcomes. And also currently it can be used, and you can see that various companies have come into the health sectors. We can use real world data to develop prediction models, and it's the foundation for artificial intelligence. So you can see big companies such as Google who have entered into health care areas and are using real world data to develop AI models. The disadvantages are, there are limitations, certainly limitations, lack of randomization, so that introduces bias, possible lack of quality control surrounding data collection because the data is already available, so what you can do with the data is as good as what the data is or how we input the data. So there might be missing data, there might be incorrect data, so all these have to be factored in. and therefore there are multiple sources of biases for comparing the outcomes, and always there is residual confounding, and that has to be recognized. Not always we will have all the variables that we would need to factor into, and therefore there is always residual confounding. And there are methodological challenges to how to analyze and interpret this data. And if we are aware of this, the strengths, but also the limitations, and and if we are conservative or cautious in how we interpret the data and make conclusions, then we can use it to our advantage. So these are the several sources of real-world data. The first one is the human fertilization and embryology data set, which is from the UK. It was established in 1991, and we collect data from every IVF cycle that occurs in the UK. And it is a mandatory licensing requirement for every center in the UK. So every individual patient having assisted reproduction, the data has to be submitted prospectively to the HFEA. And then you have other data sets. You have the American data set, and you have the Australia New Zealand assisted reproduction database. And there are several studies. Christos has published several studies from the ANZAD data set, which is again a wealthy resource, very robust studies he's published. It's got huge number of cycles from both these regions. So let us look at some examples on how real-world evidence has shaped our current practices, and I'm going to refer to the context of ovarian stimulation and embryo transfer strategies, what we have learned from real-world data and how we have adapted and how it has improved the outcomes or live birth rates or successes with IVF treatment. So this is a very early study, one of my first studies, and here I've looked at the HFEA, that is the UK National ART dataset. As you can see, real-world evidence provides huge numbers, large sample sizes. This is almost impossible if we were to consider randomized controlled trials. And here we've looked at for over 400,000 cycles to address the association between number of oocytes following ovarian stimulation, which is an important aspect of IVF treatment. 98% of IVF treatment cycles around the world have ovarian stimulation, and therefore we wanted to see what is the association between ovarian stimulation quantified as number of oocytes retrieved and live birth in a fresh cycle. And interestingly, we found a non-linear association. Non-linear association meaning there is an initial linear association, that is, initially with every oocyte number, the live birth rate increased in a fresh cycle up to 15. Then beyond 15, there was no increase, no decrease. The live birth rate remained stable. But if you had very high number of oocytes, and this is in fresh transfer cycles only, so it is not cumulative live birth rate, not frozen embryo transfer cycles, just in fresh embryo transfer cycles, when you have very high number of oocytes, that is 20 or more, and you put back in a fresh transfer, the embryo in a fresh transfer, there is a decline in live birth rate. So that is what we found, and this was published in 2011. So, and that is from one part of the world, that is from the UK. Does it apply to you? Does it apply to someone else? So let's see if there are more studies to validate this evidence. It's always important to validate any findings from research, and that gives more confidence that it can be generalized and can be applied wider to all our settings. So this was followed by another study. The first study is from the SAT, that is the American data set. Here again, they're looking at oocyte number and live birth rate following a fresh transfer. And you can see the top line, that is the purple line, and again it shows a non-linear association, very similar, mirroring what we found. Again, this is a very huge data set, more than 200,000 cycles, and they found again that the number of oocytes retrieved is a strong prognostic variable for IVF success, and in a fresh cycle your live birth increases with every oocyte number up to a certain level, very high number of oocytes, and you put back in a fresh cycle, there is a decline in live birth rate. So that's the SAT study, and it's showing exactly this very same in the Swedish data set, which is the pink line on the second figure, whereby you're seeing again a nonlinear association, increase in live birth rate with increasing number of oocytes in a fresh cycle. But when you have very high number of oocytes, don't put back in a fresh cycle because the live birth rate is declining. Then again, you have the safety aspect as well addressed in the SART data set, that is the pink line, which we all know that again, this is not something new, that if you have more number of oocytes, you have high, and you put back in a fresh cycle, there is higher risk of OHSS. And in this study, they found that clinically significant increase in OHSS at more than 15, more than 20 oocytes in a fresh cycle. So you have evidence from real-world data set, from data from different parts of the world, the UK, the US, and from the Nordic countries, all showing exactly the same. And this gives us real confidence that this evidence is true or reliable, and we can all, it applies to all our practices or all our centers. So what do we do? So this is another real-world study, again coming from the SART, the North American data set. Again, you can see huge number of cycles, 82,000 cycles. And here they're looking at 3 different groups, that is the high responders, 15 or more oocytes, the normal responders, and the poor responders. So you can see in the first column, and they're looking at the live birth rate with freeze-all, that is a frozen embryo transfer versus fresh embryo transfer. And what they found is that only in the high responders, there is the freeze-all strategy is better than the fresh transfer. So frozen embryo transfer gives higher success or higher live birth rates compared to fresh cycles in high responders, but not in the normal responders or the poor responders. So if you tie in all the evidence and try to see how this evidence fits in, we saw in the previous cycle, previous slides, that if you have a very high number of oocytes and put back in a fresh cycle, your live birth rate declines. And therefore, what this shows is that in those instances, if you freeze all and do a frozen embryo transfer strategy as first line, it's giving you higher live birth rate. So all this is real world evidence that is tying in and giving us, answers, or giving us some leads on how to adapt our practices and how to improve outcomes for our patients. So that's real world evidence. What is the evidence from randomized controlled trials? And this is a very well-known study we're all familiar with, comparing fresh versus frozen embryo transfers in women with PCOS. So PCOS women are likely to be high responders. So in these women, what this randomized controlled trial, large randomized controlled trial showed is that there is significantly higher live birth rate with a freeze-all strategy and frozen embryo transfer as first line compared to fresh embryo transfer as first line in women who have PCOS, who are likely to be hyper responders. So this again very much corroborates or very much reflects what was shown in the previous study, which is from real world data. So all this is tying in, showing that if we have higher number of oocytes, better to do a freeze-all strategy and do a frozen embryo transfer, both in terms of improving efficacy and also in terms of safety, i.e. we are reducing the risk of OHSS. So that's an example of real-world evidence and how we changed our practices. People who have been in this field for a long time would remember that OHSS rates were very high, and also when the freezing strategies were not that good, we had lesser strategies or less efficient strategies in giving safety and efficacy. But now we are at that stage where we have made significant advances with our understanding of ovarian stimulation, and also with regards to the cryopreservation strategies, that we can do a good stimulation which will increase the chances of live birth in a fresh cycle by knowing when to do fresh and when to do frozen embryo transfer, and also increases the chances of cumulative delivery rate. So what is cumulative delivery rate? Cumulative delivery is the live births resulting from one started cycle using all the embryos created from that cycle, that is fresh and frozen embryo transfers. And there is stacks of evidence, all this is real world data, all the papers showing that there is a consistent positive association between the number of oocytes retrieved and cumulative delivery rate. Again, real-world data, so looking into safety practices, what we have to bear in mind, that is IVF, IVF and ART success is not just live birth, but safety as well. Safety is paramount, and safety means reducing the risk of OHSS, which we saw in the previous slide, but also with regards to safety in pregnancy and neonatal outcomes. And here is real-world data as a group of fertility fraternity. We have been hugely criticized by our obstetrician colleagues in giving iatrogenic risks such as multiple births and multiple pregnancies, which increases the risks in pregnancies, neonatal outcomes, and long-term outcomes as well. Here is some real-world data showing that we have been doing fairly well over the years, and here it is showing data across 3 regions. Live birth rates, that is triplet and twin birth rates over the years. So the figures, the first set of figures is looking at multiple pregnancy rates, twins and triplets from 3 regions, that is Australia and New Zealand. The bottom line, the middle line is Europe, and the top line is America. The different regions, based on their practices, vary in their rates of multiple birth rates, multiple pregnancies, but what we can see is that across all 3 regions there is a decline in multiple birth rates over the years. So we are improving in how we are delivering, we're delivering our ART cycles and ART treatments safely to patients, and this is a result directly of us adopting actively single embryo transfer strategies. And as you can see in the next figure there, which looks at single embryo transfer strategies, you can see that we have increased the uptake of single embryo transfer strategies over the years across the 3 regions. Of course, Australia and New Zealand is doing much better than the rest, than Europe or America in adopting single embryo transfer strategies. And there could be reasons to it. Perhaps in the discussion we can open up. Michael could enlighten us why there is much higher uptake of single embryo transfer and much safer practices there compared to other regions. There are no data from India or other regions to look at multiple pregnancies, but I'm sure they will be much higher. Again, safety looks at looking at beyond neonatal outcomes as well. So here is some data, from real-world data from the United States, from the Massachusetts region of United States, looking at pregnancy outcomes and neonatal outcomes. And here we're looking at a fertile cohort compared with the infertile cohort, infertile but not IVF treatment, and then another cohort is infertile and IVF treatment. So we have 3 cohorts, and what it shows is that there is a higher risk of pregnancy complications in the infertile cohort compared to fertile cohorts. So background infertility itself is a risk factor, and also by doing and pregnancies following IVF have an even higher risk of pregnancy complications such as gestational diabetes, pregnancy hypertensive disorders in pregnancy. So infertility itself is a risk factor, and IVF pregnancies have a higher risk of these complications in pregnancy. And the same with neonatal outcomes. Compared to the fertile cohort, infertile pregnancies or deliveries following in infertile women have higher risks of preterm birth, low birth weight, and IVF pregnancies have even higher risk compared to the infertile and the fertile cohorts. So that's from North America. There is data again, real-world data from the Nordic countries. That is the CONART-S data. We said previously that if there is evidence coming from one part of the world, from real-world data sets, if it is validated from data sets from another part of the world, or perhaps from your own settings, then it gives us more confidence that it is very reliable, more robust, and more applicable. And here is the CONART-S data. In this figure, you can see in the dark blue is the frozen embryo transfers, the pink is the fresh embryo transfers, and the spontaneous is the light blue or light green, whatever the color you can see. I can see it as light blue. And what it shows is that the fresh and the frozen embryo transfers have higher risk compared to the spontaneous conceptions, and within the fresh and frozen embryo transfers, now it is common knowledge, but when this evidence came early on, it shows that there's higher risk of preterm birth, low birth weight, and small for gestational age with IVF compared to spontaneous conceptions. But again, in the frozen embryo transfers, there's a higher risk of post-term birth, macrosomia, and large for gestational age compared to fresh embryo transfers. And finally, we've looked at that, said that IVF has higher risks in pregnancies compared to spontaneous conceptions or in infertile women who have not had IVF. Does ovarian stimulation introduce any risk? We do ovarian stimulation day in and day out, or do anything which we do increase the risks, or how can we adapt our practices to reduce these risks? And this is a systematic review where we looked at stimulated versus unstimulated IVF and looking at risks of preterm birth and low birth weight, and we found that there's a higher risk of preterm birth and low birth weight with stimulated compared to unstimulated IVF cycles. But what is important to bear in mind is that the absolute risk increase was low. So when there are risks with anything, you have to weigh the risks and benefits and then take a judgment on how you think you should be changing your practices or adapting your practices, or how you counsel your women. What we did further is that, and we looked just at singleton pregnancies because multiple pregnancies are confounders. And what we did is, yes, we saw that there was a slight increase in preterm birth and live birth rate with ovarian stimulation compared with unstimulated IVF cycles. But is there any correlation with the intensity of stimulation or the number of oocytes retrieved? And what we found is that up to 15 oocytes in a fresh transfer cycle, there was no increase in preterm birth or low birth weight, up to 15 oocytes. But if you had very high number of oocytes, more than 20, and then put back in a fresh cycle, only then you're introducing a higher risk of preterm birth and low birth weight in following with very high, if you put back in a fresh cycle. So we've seen from previous studies that when you have very high number of oocytes and a fresh transfer, the live birth rate declines. What this study is showing that when you have very high number of oocytes, you do a fresh transfer, that there is an increase in low birth weight and preterm birth. So again, it's saying that with very high number of oocytes, it's better to do a freeze-all strategy and avoid a fresh embryo transfer. And this is another study which came from the United States, very similar to the similar time as to the study we published. And here they're looking at estradiol levels in a fresh transfer cycle and birth weight. And what they found is that when there is very high supraphysiological levels of estradiol and you have a fresh embryo transfer, there is a higher risk of low birth weight. And this again, although they're looking at they're looking at estradiol levels, association between estradiol levels and low birth weight in a fresh transfer cycle, and we are looking at number of oocytes and preterm birth and low birth weight. We can tie both the evidences in the sense that when we have very high number of oocytes, we're expected to see very high estradiol levels, and what they found is that when they have very high estradiol levels, there is a significantly higher incidence of low birth weight. So it's all tying around together, and it's also saying that with a very high number of oocytes, you can introduce safety, avoid the risk of OHSS, give a better live birth rates, and also reduce the chances of preterm birth and low birth weight by not doing a transfer in a fresh cycle and doing a freeze-all strategy. So from real-world evidence, what we have learned and what we have adapted over the years is that we now know that there is a decline in live birth rate following embryo transfer in a cycle with very high number of oocytes. There's higher risk of OHSS depending upon the protocol, the stimulation protocol or strategy you use, with more than 15 or 20 oocytes and transfer in a fresh cycle. There is higher risk of preterm birth and low birth weight with very high number of oocytes. In our study, we said there was higher risk with more than 20 oocytes and transfer in a fresh cycle. We also saw that there is a higher live birth rate with freeze-all strategy and frozen embryo transfer in high responders in PCOS women, both from real-world evidence and randomized controlled trials. And we also saw that by adapting this strategy, tailoring your stimulation, tailoring your embryo transfer strategies based on which categories these women belong to, we can increase our cumulative delivery rates, we can have an OHSS-free clinic, and we can deliver the best outcomes to our patients. Can we build on real-world evidence even further? Yes, we can. Health economic evaluation can be combined with real-world evidence to guide clinicians and policymakers. This will come in the next lecture. Astrid will kindly follow me on with this. And understanding health economic evaluation can help make best use of real-world evidence in practice so that the resources available can be used to optimize outcomes for patients. Thank you very much.